So examinations, like I told you, now since we have gone with the age, the history taking, and we have gone with, see, now we have gone with the history taking, the color of urine, the characteristics of urine, the associated symptoms we have gone, and now we are going to go with the examination, coming up with examination. So whenever a child with hematuria comes to you, always, first of all, don't miss taking a blood pressure, because 95% of the pediatricians, they always miss taking blood pressure, especially in their OPDs, because they don't take blood pressure because say, it's okay, it's a UTI, so let's leave it and let's see how the things are. But the most important thing is to check for blood pressure. If there is hypertension, then you're delaying your diagnosis. Temperature, I get to fever, edema in cases again, pallor for bleeding disorders, or any hemolytic syndromes or sickle cell anemias. If there is HUS, SLE, where we find certain rashes on the body, so you have to check for that. In cases of congenital heart diseases or CCF, you find increased raised JVPs. And obviously, when you examine for abdominal examination, any mass to rule out Wilms tumor or any other abdominal mass where you are having a suspicion that it may lead to hematuria. So you should check for abdomen examination, bladder examination, and tenderness is there or not. That examination will check. So let's come to a general approach to how we investigate a child with hematuria. So let's go with investigations. Now we have basically taken the whole history. So we have seen that our child had come with mother with a history of hematuria, with a history of fever and just which was there for 10-15 days back, and you have examined him and there's no finding as such. So the first investigation which you are going to advise is a urine dipstick test. Now it can detect the trace elements of a hemoglobin or RBCs or even a myoglobin in the urine, and it can detect 5 to 10 intact RBCs per mm of unspun urine. That means unspun means uncentrifuged urine. Sometimes if the urine pH is more alkaline, then it can give a false positive test, and also go with a urine for albumin if you are having a history of frothy urine. Then urine microscopy, like we have to check it out. So just sorry. Urine microscopic examination. The most important examination is presence of RBCs and CAS more than 5 RBCs per HPF in centrifuge urine, which defines hematuria. So I have already discussed this, but I'll still come to that point. Glomerular and non-glomerular. If it's a brown, cola-colored or smoky urine, glomerular cause. If there are RBC casts in the urine microscopy, go for a glomerular cause. Proteinuria 2+ or more, again, go for a glomerular cause. And deformed urinary RBCs, it should be a glomerular cause. If it's a bright red or a pink urine, if it's a terminal hematuria, where you find that the parent is saying that there are, clots are passing in the urine, or if there is a normal morphology of RBCs, and if this proteinuria is less than 2+, then you can think about a non-glomerular cause of hematuria. So now let's come, if the child is having a cola-colored urine, which is basically a glomerular cross or an RBC cast, where we are finding proteinuria of more than 30 gram per liter. So if it's a yes, if you find cola-colored urine, proteinuria of more than 30 milligrams RBC casts, so whether I should think it's a glomerular hematuria or I should think it's an extraglomerular hematuria. So if I think if it's a glomerular hematuria, so what are the set of investigations I will further? So all the regular investigations like CBC, CRP, electrolytes, calcium levels, your lipid profile, which includes your cholesterol levels, then serum protein and albumin ratios. Then the most important thing comes is the complement levels, which is the C3 and C4 levels, ANA titers, ASO titers to rule out post-streptococcal infections, ANA antibodies, dsDNA antibodies. If there is a history of a fever 2 weeks back, and that was preceded by a throat infection, Better if the patient is actively in that phase, get a throat swab done, and if there's a skin infection, get a skin culture done. And obviously, a 24-hour urine protein creatinine clearance is important. So these things you have to look out for if you are thinking about glomerular hematuria. So these are a set of investigations which you should go as a blood investigation, which are important. Non-glomerular cause, if extraglomerular hematuria, get a urine culture done with a urine routine, obviously. Then a urine calcium and a creatinine ratio, renal and bladder ultrasounds, urine analysis, serum electrolytes, and if there's hydronephrosis or any other congenital anomaly, go with a cystourethrogram or a renal scan. See, this is a big slide. If urine culture is there, a renal function test is there, if blood urea nitrogen and serum creatinine level should be done. And you have to remember what I'm writing is exactly not the same what you can find. But yes, it will lead to your diagnosis. So if there is a low serum sodium levels, it is basically acute glomerular nephritis. If there is increased potassium levels, we all know it's a renal failure. It's an acute renal failure. CBC is if the hemoglobin is going down, and if you're finding in the peripheral smear that signs of hemolysis are there, then you should think about sickle cell disease or any hemolytic diseases, HUS, SLE, and go ahead with the PTA, PTTs, and see if the child is landing up into DIC because of some long-term infections. Platelet counts and coagulation studies, I've already told you. ESR and CRPs, if the ESRs are very high, CRP is persistently going on very high even after the antibiotics, then think about any autoimmune diseases and try to rule out those things. And like we told you to go with the complement levels, ANA, DS, DNS, and go ahead with further investigations. So 24-hour urine protein, spot urine protein versus creatinine ratio, serum albumin and cholesterol ratio, if accelerated proteinuria is there, to rule out nephrotic syndrome. Urinary calcium, this is very important in cases of hypercalciuria. If you find that the 24-hour urinary calcium levels are more than 4 milligram per kilogram per day, or if you do a spot urine calcium creatinine ratio, if it is more than 0.21%, then you can think about hypercalciuria, right? Okay, now we go with the imaging studies. See, the imaging studies, the renal and bladder ultrasounds, and this, like we told you, for any urinary tract anomalies, hydronephrosis, hydroureter, calcinosis, any tumors, urictiasis, renal cavernous diseases. So the first and foremost is get a KUB there. KUB is a kidney, ureter, bladder, renal or bladder sonography, which is the prime investigation. Please don't land up into bigger investigation. The first thing, whenever the child comes into you, into your OPDs, don't tell them, okay, go with the Doppler study, go with the cystourethrogram, or go with the, spiral CT scans or any other MRIs. First, go with the basics of a renal and a bladder sonography, X-ray, KUB to rule out a calculus. Then think about a Doppler study of renal vessels and IVC to rule out renal vein thrombosis. Then we go with the intravenous urography. Then I would preferably go with the micturating cystourethograms to rule out any urethral bladder abnormalities in cases of urethritis or UTIs or vesicular refluxes. And finally, I would then go with radionuclide studies to know the renal functions and perfusions, whether the renal functioning is okay or not, whether the child is having any other symptoms of Alport syndrome or anything else. Then go with angiogram and chest X-rays to rule out any CCS. Okay. Now, if all the investigations have been done and you found that we are not leading to a diagnosis, then the final investigation which you can go ahead is a renal biopsy. But preferably, what we do in our practice is till this investigation, still imagining studies we can do. But during the imagining studies, what I preferably do is I take a nephrologist with me in team and take his opinion on that. And maybe then if all the investigations are being done and we are still not reaching a diagnosis, to get 100% diagnosis, then we, along with the help of a nephrologist, go ahead with the renal biopsies. So when what are the relative indications or criteria of renal? See, this may be an old slide. If anybody has a new perspective to this, I'm always happy to have inputs on them. So significant proteinuria 3 plus or more, and recurrent nephrotic syndromes even after the oral steroids and other medication like methotrexate and all, recurrent persistent hematuria for more than 2 years, abdominal renal functions, persistent hypertension, hematuria, proteinuria, diminished renal functions, low C3 levels, uh, absence of any other, like I told you, absence of all the investigations coming out to showing any positivity and any abnormal or dsDNA levels and a family history of end-stage renal disease, then yes, you should go ahead with a renal biopsy. I'm not going into the details of these because these things can be noted in the, the histological section, and then maybe you can talk out with the histopathologist and then maybe transfer the patient to the nephrologist for further management and all.